Good afternoon.
Good afternoon. I'd like to present AB 1300, which would authorize emergency room physicians and psychiatric professionals in non-designated facilities to place 5150 holds. 5150 is a section of the Welfare and Institutions Codes in a manner similar to peace officers in order to obtain evaluation and treatment from a designated professional or to arrange the transfer of a person on the hold to a designated facility. The Lanham-Petra Short Act governs the involuntary detention of individuals for psychiatric treatment. It was enacted almost 50 years ago, and in that time it was envisioned as an evaluation and treatment of people with mental illness throughout designated facilities across the state. There have been significant changes in the mental health delivery system since the passage of the LPS Act that have adversely impacted our ability to provide evaluation and treatment for this very vulnerable population. As resources for psychiatric facilities have declined, peace officers, individuals, and families in the middle of mental health crises have turned to emergency room departments for relief because of convenience and necessity. Because the LPS did not contemplate emergency room departments serving as a necessary entry point to the 5150 process, emergency room physicians often lack the legal authority to place a 5150 hold on an individual that they believe might need psychiatric services. Instead of ignoring the growing problem, emergency room physicians have to be asked to be a part of the solution. By granting emergency room physicians and psychiatric professionals the authority to place these holds in a manner similar to peace officers, we will improve public safety and outcomes for individuals and families that are working through the challenges of a mental health crisis. We have witnesses that can attest to the merits of the bill. We thank the committee for indulging in the dialogue. Thank you, Mr. Chair.
Good afternoon, Senator and members. Elena Lopez Guzman on behalf of the California chapter of the American College of Emergency Physicians. This bill has had lots of different provisions over it over the life of the bill, including a lot of opposition, but the bill as it stands before you has been dramatically reduced, and it contains three essential pieces in providing higher quality and more timely access to care for persons facing psychiatric emergencies. Those three provisions of the bill are, first, it places a requirement on hospitals that they must accept all patients in psychiatric crisis regardless of their ability to pay. So similar to the requirement that's in current law for every other medical condition, when we have somebody who needs to be transferred to a higher level of care, that hospital must accept them regardless of their ability to pay. We want something similar in statute for people with psychiatric emergencies. We think that's a strong consumer protection, and that's in this bill. The second provision of the bill is that it allows for information sharing among mental health providers in the context of emergency services. We have a statute on the books in California that has stronger patient protections than HIPAA with regard to persons with mental illness. And what that has done in California is that has prevented emergency physicians from gaining complete access to people's medical records. So for example, if you have somebody who comes in, we're unable to see perhaps what medication they are on, who their care provider is, what care plan they're on. And so the provision of the bill allows us to see their complete medical record just as we would be able to treat anybody with any other chronic or acute condition and seeing their full health record. The third provision of the bill is the one that the author well described and is the one that has been the most contentious in this piece of legislation. And that is the ability of the emergency physician to place a patient on a 5150 hold for purposes of receiving care in a designated facility. And let me explain to you in real life terms what that means and who we're trying to help. It means that if on a Friday night, your sister, your uncle, your cousin, your loved one, your friend is in a psychiatric crisis and they are suicidal and they need help, you take them to the closest emergency department because that's the right thing to do. You know that they need help. You come into the emergency department, and it happens to be a non-designated facility because in California, most hospitals are non-designated facilities. The emergency physician makes sure there are no other medical conditions that need to be treated, and it becomes very clear that that person needs psychiatric care. At 11 o'clock on a Friday night, that emergency physician cannot get that patient into the designated system that we have in California. The 5150 is the on-ramp to that system. What we are asking for is the ability for emergency physicians to get their patients the care that they need more quickly. So what will happen then is that patient will wait in the emergency department, hopefully, because they have to do it of their own will. Hopefully they'll wait in the emergency department for 2 days until either a psychiatrist who has been designated that facility comes on staff on Monday, or the county PET team comes around and they place a hold. And so what you're waiting for is just the place in line to get into the system. There are absolutely delays in care because we don't have enough capacity. That is true. We need to build more capacity. But even if we built all the capacity we needed, we still would not have addressed the issue that I'm presenting you today. The emergency physician still would not have the ability to get that patient into the system that we've built. So we still need to address this problem. We look at this as a parity issue. This is no different than if another patient comes in and has a condition and they need to see a urologist. We don't have a urologist on staff. We can transfer that patient to a hospital with one. We have a burn patient who needs a higher level of care and we need to transfer them to a burn facility. That's where we transfer that patient. Why is it the mental health patient is the only person who the physician cannot get the higher level of care that they need? So we look at this as a parity issue. We know that there's been a lot of opposition. We know there's still some concerns with the bill, even as it's pared down. We are not trying to create a separate system. As I said, we're trying to create access to the system that exists in a faster manner. We're willing to look at, if the committee passes this bill out today, we're willing to look at amendments that would require training for emergency physicians with respect to the 5150 hold process, which they currently do not receive clinically. We're also willing to look at county oversight of the holds that emergency physicians would be allowed to place. There is county oversight already in the current LPS system. It makes sense to extend it to this. So we're willing to look at those things. But fundamentally, we have a problem that our patients are facing. They're in our emergency departments asking us for help, and we do not have the tools necessary to get them the help that we need. And so we ask for your aye vote to help us with that.
Thank you. Anyone else in support?
Mr. Chairman, members of the committee, Randall Hager for the California Psychiatric Association. We strongly support the emergency physicians in this. I think a couple of quick examples to underscore, I think, what the real-life consequences are. In a family with a young child with severe emotional disturbance, the child may come home after school, get into an altercation with his brother, start beating him with a broom. Mom intercedes. A ball is thrown. She narrowly ducks and avoids it. Dad is called because it escalates and she can't calm him down. And somehow they get him into the car and they get him into the hospital. There is every, I think, indication in that kind of scenario that we would want there to be a safe place. We would want that family to be able to move their young child into a treatment situation where these issues could be addressed and evaluated and treated. So the other would be another real-life incident that I am personally aware of. There was a homeless man who was unconscious on a sidewalk here in Sacramento. The police were called. Police called EMTs. EMTs found him breathing but unresponsive, and so they loaded him up and took him to, I think it was the Sutter Emergency Department. While there, the person sort of came back to consciousness. They found out he was not only mentally ill, not only homeless, but mentally ill, and he was very, very gravely disabled in the opinion of the physicians there at the emergency room. This bill would allow those kinds of individuals to move more expeditiously into care, specifically in the designated hospital system that is sort of the object where we want to send people. And so I would also echo what Ms. Lopez Guzman has said in respect to this bill. It does not create a separate system of care. I argue that already in the location where the emergency physicians have been placed in the statute, that they would be subject to county oversight. They would be subject to civil rights protections and the procedures thereof. So if that needs to be tightened up, if that needs to be clarified, we're certainly willing to do that. Thank you.
Please proceed.
Chairman and members, Barbara Glazer with the California Hospital Association, here today as a co-sponsor and in strong support of the bill. Very simply, we hope this bill will allow us to care for these patients much sooner than they're getting care right now. Get them into the right treatment in a more timely manner. It's that simple for us. We urge your support.
Anyone else support?
Amber King with the Association of California Healthcare Districts in support.
Thank you. Opposition? We can make some room for the opposition up here.
Thanks, Randy.
Mr. Chair and members, Karen Savage, National Alliance on Mental Illness of California. First, I want to thank committee staff and the author staff for all of the hours and work that I know has gone into this bill. We are here in respectful opposition. We represent individuals and family members who live with serious mental illness through our 62 affiliates. The Lantrum and Petrus Short Act that we're talking about today was created in this state 50 years ago to move us from the institutionalization of people who are living with a serious mental illness towards a community-based recovery-oriented system of mental health care. And so I think it's important to think about this reworking of that act in that context. The LPS Act establishes strict criteria for who may be involuntarily detained, under what conditions, and the facilities that may detain people, and the services they must provide, and the patient's rights protections that they must provide. And unfortunately, the bill before us today, Assembly Bill 1300, moves away from the intent of the LPS Act. It allows individuals to be detained in hospital facilities that do not meet the rigorous standards outlined in the LPS Act by emergency room physicians who are not authorized under the law or trained to follow the criteria established in the Act to prevent unnecessary detentions. And I think it's really important to note that individuals should not need to be involuntarily detained in order to receive mental health care, in order to access our county system for care, or in order to receive the appropriate services that they need. So AB 1300 undermines the ability to provide appropriate treatment to our most vulnerable patients in several ways. Some of the requirements that designated facilities currently meet under the LPS Act that patients who are put in non-designated facilities under this bill are maintaining clinically appropriate and safe environment for detained individuals with mental health needs, providing mental health assessments, programs, and treatment for all involuntarily detained patients, meeting state law requirements and national standards for the use of seclusion and restraint, and ensuring that all staff involved with the care of these patients understand both the LPS Act and appropriate mental health care. So these are things that we currently provide in our designated facilities that would not be provided to patients who would be detained for 72 hours in these non-designated facilities under this bill. And for those reasons, we are opposed to the bill still and today, but we do support continued work on this issue. We think there are great pilot projects happening, including in Los Angeles County, and we would urge the sponsors and the author to continue to work on those issues as well. So we do urge your no vote today. Thank you.
Mr. Chair, committee members, Douglas Chiapetta on behalf of the Union of American Physicians and Dentists. We are the physicians in AFSCME. Our overriding concern with regard to this legislation has been addressed in amendments that have been taken by the author, Mr. Ridley Thomas. We appreciate that. Initially, the bill would have prohibited a psychiatrist to have an input in evaluating a 72-hour hold, the 5150 holds that we've been hearing a lot about. That has been eliminated in this bill. However, there are some other areas within this legislation with regard to patient safeguards that have been alluded to by NAMI that we're still a little bit concerned about. So going forward, we still maintain our OUA position, but by and large, our overriding concerns have been addressed. Thank you.
Mr. Chair and committee members, my name is Jacqueline Zanowski, and I'm here on behalf of Disability Rights California, and we oppose this bill unless it is amended. We have been working with the sponsors on amendments to address our concerns and are surprised with the current amendments. These current amendments are troubling because they sanction holding people for 72 hours in emergency rooms and may encourage serial holds. Serial holds are when a person is in an emergency room is placed on another hold at the end of those 72 hours. This could lead to people remaining longer in the ERs, which is something we thought that the sponsors were trying to avoid. We are concerned people will not be quickly transferred out of the ER into a designated facility for assessment and treatment. or released if they no longer meet the involuntary hold criteria. Thus, an individual could spend 72 hours or more in an ER facility without receiving appropriate assessment and treatment. This is contrary to the current law and is not supportable by DRC. We understand that there has been a stakeholder meeting to address some of these issues, but until we have a chance to review specific bill language, we must be opposed. For these reasons, we oppose this bill unless amended and urge you to vote no on it.
Good afternoon, Mr. Chair and members. Adrienne Shilton with the County Behavioral Health Directors Association. We represent the public behavioral health authorities in counties throughout the state, and CBHDA is opposed to Assembly Bill 1300. First, I'd just like to take this opportunity to thank the committee staff for their excellent analysis of this issue. It's a complex issue, and I think it's summarized very well in the committee's write-up. Also like to thank you, Senator Hernandez, for your work with us on this and your thought-provoking and thoughtful questions when we met with you on this issue. We're opposed to AB 1300 because this undermines county mental health authority to regulate conditions under the LPS Act. Emergency department physicians who are certified by the county mental health plan to initiate detentions under 5150 do so with very specific mental health training. And further, the LPS applies specific patient protections, and it's unclear to us how the client is protected under the proposal on the table. Counties do designate emergency department physicians now to detain under 5150, and it's all done in a framework to ensure proper care and proper accountability. As the staff analysis portrays, there's a lot to build on in California. California counties have stepped up to apply for SB 82 grants in terms of expanding the crisis capacity in our system. So counties are building new crisis residential facilities, crisis stabilization units, establishing mobile crisis teams. CBHDA was also worked to support Senate Bill 364, which modernized the LPS Act, and among other things, expanded the number of facilities that could be designated. So we feel like there's a lot to build on. We also feel that the issues that the sponsors are trying to address are multifaceted and require bringing all of the stakeholders together to really look at the solutions to these challenges. And so we would respectfully urge the committee to look at holding hearings on this topic to delve more deeply into the issues. We want to be part of the solution. This has always for us been about access to psychiatric care, quality of care, and the client's experience. It's never been about the facility, it's always about the client. So thank you very much.
Mr. Chair and members, Michelle Cabrera with SEIU California, and we must respectfully remain in opposition to AB 1300. We would like to thank the author and the sponsors for their engagement and conversation and for their willingness to look at the amendments that we proposed to this bill. Unfortunately, we don't believe that the framework that they agreed to goes quite far enough, and the reason is that this bill would essentially create a parallel process whereby non-designated facilities could place individuals on a 5150 hold, but they would not have to meet all of the rigorous standards of other designated entities. And so it essentially gives a non-designated hospital the rights of a hold, but it doesn't give them the clarity about what the commensurate responsibilities are. And these are things that we take very seriously. As you've heard from my colleagues with NAMI, CBHDA, and Disability Rights California, it includes things like training for the staff about what the LPS Act is, what it means to take someone's civil liberties away from them and place them on a hold, which is a very serious matter. It also helps them to understand that they must meet certain rigorous staffing requirements, and that was one of the things that was not on the table. those staffing requirements are outlined in law, and they're meant to ensure that the staff at these facilities understand that practices such as seclusion or restraints should not be used in lieu of not having adequate staffing. So really making sure that what we're doing here is not trying to set up a process that is that parallels what police officers have in terms of their training and ability to get folks to care that they may need, but that these are medical facilities which have the ability to have appropriate staffing personnel as well as mechanisms, and that it really is a different thing to actively engage in holding someone than it is to place someone on a hold. And so for all of those reasons, we must respectfully remain opposed.
Thank you. Any other opposition?
Yes.
May I have a moment, or?
We've pretty much exhausted. We can just, if it's very brief, otherwise I'd appreciate just
Very
name and
brief.
position.
My name is Heidi Strunk. I am with the California Association of Mental Health Peer-Run Organizations, CAMPRO. We're a statewide organization with membership of over 37,000 individual members with lived mental health challenge experience. We absolutely oppose this bill. It's a threat to our civil and due process rights. There's a huge issue regarding immunity to public agencies and hospitals and their employees, especially given the history of abuse of individuals under the guise of treatment. And just lastly, this bill is really convoluted and non-transparent, makes major changes to the LPS language, and therefore it may have unwanted and unforeseen ramifications and consequences. Please oppose this bill. Thank you.
Thank you. Just name and position, please.
Mr. Chair, members, Christopher Castillo on behalf of San Joaquin County in opposition.
Mr. Chairman, Michael Radigan on behalf of the Board of Supervisors of Santa Clara County, but for the record, we have removed our opposition.
Thank you. Questions, comments? Yes, Senator Roth.
Just a couple. You mentioned initially the training for the emergency room physicians. What sort of training does a peace officer? My understanding is a peace officer can place an individual on a 5150 hold, correct?
That's accurate, Senator.
So what training does a peace officer have?
A post-course, 3 hours at the beginning of their work through the academy. That's the extent of the peace officer training associated with placing a 5150 hold.
Yes, ma'am. Thank you, sir.
May I? So we've actually, last year, we extended the training to peace officers, and a specific part of their training is the LPS Act and understanding the requirements in the LPS Act, and there's a specific probable cause standard for taking individuals into custody under the LPS Act. So peace officers are specifically trained on that, and that's not training that emergency room physicians who are not specifically designated would have. Currently.
But presumably that would be a fairly easy fix. We're talking about highly educated individuals who are used to dealing with healthcare and medical issues. In fact, life and death issues very quickly in an emergency room or trauma setting. So it would seem that that training piece could easily be adjusted should this bill move out as this bill moves through the process. Let me go to my second question, and that has to do. Somebody mentioned initially that a scenario where an individual, a family member, or relative, friend is suicidal or appears to be disturbed, is taken to an emergency room in the local hospital. Not unlikely, probably not uncommon. Is it in fact true that at least in some cases, if not many cases, the individual would otherwise sit in the emergency room if they chose to do so voluntarily and wait for a day or two for the county system to catch up to itself and for a psychiatrist or a psychiatric team to visit the emergency department and either place the person on 5150 or allow the person, if presumably they're not detained, but encourage them to leave?
Senator, that's the case, and it's different in different counties. In Los Angeles County, there is a tele 5150 program that is unique to the state. It's believed that it's allowed under the statute currently. But anywhere else in Southern California or in the rest of the state, you may find more instances where you just have to wait for the current system to catch up. And that's not an ideal set of circumstances.
Any comment from the table? Because then I have a follow-up question, depending on what you say.
So, AB 1300 doesn't change whether people get psychiatric care in a non-designated facility, and that's one of the concerns.
But my question goes to, if you don't have an individual in the emergency room at the non-designated hospital to make a determination, assuming they're properly trained, that the individual needs to be placed on a 5150 hold, and you pick up the phone and you call, how long do you wait to get someone in the door to make the determination?
Depends on how long it takes, Senator. Sometimes that's just the nature of the system. In Los Angeles County, here's another thing.
It's quick, but how about San Bernardino, Riverside, YOLO?
So,
It's in the emergency rooms now, Senator.
under current law, all emergency room physicians in all hospitals can place a 24-hour hold, and that's under a different section of law in our health and safety code. That's current law. They can and they do use that hold.
Without any training?
Correct, but that's not part of the LPS Act, and that's for 24 hours, and we extended it from 8 to 24 hours in 2009. And I think that's one of the other issues to consider, is I think we should look and see, is that working? How well is that working? Do changes need to be made, right, before we change it again from 24 to 72 hours? And again, as I said, that's not part of the LPS Act. That's in the Health and Safety Code. So none of the provisions of the LPS Act apply to that either. So
If I might, Senator, that's an important distinction. You're absolutely correct. There is a provision of the Health and Safety Code that allows emergency physicians to hold somebody with immunity from liability for 24 hours. The distinction that the fact that it's not in the LPS Act is significant. It is not the entryway to the LPS system. So while one of my members can place somebody on a 24-hour hold, that's essentially a circling pattern, waiting, again, as I mentioned, for the county PET team to come around and place the 5150 hold, which is the ticket to the LPS facility. My member cannot pick up the phone and get them placement in an LPS designated facility on a 1799 hold. They will not accept them. They must be on a 5150 hold in order for them to be accepted. So all we're doing is prolonging the length of time that that patient is not receiving the care they need, and they're just being stuck in the emergency department.
Well, any other comment? I mean, I'm interested in this. I will tell you, when I was on the board, been on the board of a few hospitals in my very old life. But I remember being on the board of a hospital when an individual reported having attempted suicide drinking antifreeze. We could not find a bed for that person. And that person, while waiting for somebody to show up, actually made good on what he intended to do, despite the watch that was put on him, by finding the exit to the 5th story and took a jump. So I'm very concerned about this, and I'm very concerned. I mean, I understand, you know, the act and needing to make training and have the act apply to non-designated facilities, have the facilities trained in some way, have the procedures spelled out. If there's staffing issues, having the staffing addressed. But it appears to me, perhaps in my very uninformed being, that our system is inadequate, and we have to expand the system, and we have to expand the services to take care of these very, very vulnerable people. And if training some emergency room physicians, if putting some procedures in place, if requiring some additional staffing, I can understand that with mentally disturbed individuals. We need to take some sort of action. response?
Yes, thank you. I mean, I completely agree, and I think there's no one at this table who does not agree with the fact that we do need to do more in this area. The challenge is that unless you get very specific, as we have in the LPS Act, about what it means to put someone on a hold, the unintended consequence will be that ER physicians and non-designated hospitals will, and we think this may be unwilling, some, depending on their knowledge or background about what they're doing, lead to patient dumping. So I'll give you an example, and it creates no incentive for hospitals to want to become designated, because there is a lot attached to that right. There are a ton of responsibilities. It's not an easy thing. We've already seen the private hospital industry divest of inpatient psychiatric beds, and so we're concerned that this will lead to further divestment in this very important area, and that if we're going to have a conversation, we have to do it in a way that supports building up the services rather than just moving the problem, and that we're concerned that more people could get captured on 5150 holds where it's not appropriate, and that would be a real problem for the people who actually do need the care, because then you're sending that person who's maybe chronically homeless and maybe has a substance use problem, and who the ER just doesn't want there anymore. They put them on a hold, they call the county, they say, get them out of here, but then that person who doesn't really need to be on a hold is taking up space and interfering with the therapeutic environment of the people who really do need to be on hold.
Well, that leads to, Mr. Chair, may I have one more? That leads to another question that just occurred to me. So if an emergency room physician has the authority to place a person on a 5150 hold in a non-designated facility, does that same physician have the authority, I assume, to release the detention under this bill?
The bill is silent on that, so, there's nothing to say that they couldn't.
The bill used to contain a provision that allowed an emergency physicians to release the bill. We removed that due to the substantial opposition to that provision. This is only designed to allow the emergency physician to place a hold, and it specifically says in the bill, for purposes of sending them to an LPS designated facility for the care that they need. It is for purposes of getting them to the care point.
Okay, well, thank you, Mr. Chair.
Thank you. I believe we have Senator Nielsen, and if time, we have Senator Mitchell, but they both have to get to budget. And then I have some comments, and I have some suggestions and a recommendation.
Mr. Chairman, I'll make it quick. First blush, I was not really supportive, but let's say I've had a lot of experience with this area. As chairman of the Board of Prison Terms of California, we did the mentally disordered offenders, the psychiatric revocation hearings over the years. So I've dealt with 5150s for a long, long time. And since, because of actions of this legislature after several years, a lot of people with mental health needs who are in fact dangerous to themselves and others, who need treatment that's not available in the community, who go off meds, and they now do not have parole supervision, don't go to parole outpatient clinics. That's just part of this population, but they're out there. And for a number of years, I've been getting calls because of people knowing my experience saying, Jim, I've got in the ER a problem child, or parole's just dropped this guy off from DVI or Solano at the ER, and he's in a bad state. Well, they don't have any way of dealing with this. And the individuals need more, and in one case, they just sent him off, but got him in a motel room. The issue is they are a problem to the community, to themselves, and to the people in the facility, in the ER. So at first blush, kind of not being really sympathetic, but we have a serious problem. And I'm willing to support this legislation for now, because we do have one. Now, as the legislature responds and works with the community to change the dynamic, so these individuals that are absolutely out there, they are there on our streets. If we have more treatment opportunities and options and ways to deal with it, then fine. Maybe we can roll back and have the kind of treatment individuals doing the evaluation. But we don't have that now. We do not have the psychiatric people in the ERs. So I'm willing to delegate that at this crisis time.
I'd like to make a couple of comments and then some suggestions and a recommendation. Do you mind, Senator, then here, make some suggestions, then maybe have the chair, the assembly member react. Okay. So there is definitely a problem with regard to mental illness coming to the emergency room, but I think it's not only that, but we also have a capacity problem. I understand that there has been dialogue going on throughout the time, and unfortunately, because we're at the last date, we don't have a resolution, and we're still pretty far apart. I'm not prepared to support the bill in its current form because I don't think it's close enough, but what I am prepared to do, if you're okay with it, is to move the bill with the understanding that we have resolution between now and appropriations, and if we don't have resolution, that you not move the bill, but that we work with you to come up with a solution. So here's my thoughts. So we have an LPS Act has been around for a while. We have designated facilities. You have patients that go to the ER that need to have attention, but the problem is you don't have, could be a disconnect, but maybe there's not even enough designated facilities, and how do we get the ERs to become designated facilities? So I heard the proponents make on a comment that they'd be willing to look at appropriately training currently professionals, so that can solve part of the problem. I also heard from the proponents there'd be a willingness to have county oversight. I think that could be part of the solution, but we need to also have in the conversation capacity and bed space. Because without the capacity and without the bed space, all the training is not going to solve the problem. And I think if we work towards that and there's a commitment that we can actually get these individuals into the appropriate facility, whether it's in the hospital that is overseen by the county with appropriate training or into a designated facility, the goal is ultimately that the patient's safety and healthcare is of utmost importance. So if there's an agreement from the author that we can work on this until appropriations, and we'll be involved as well, that there needs to be a resolution by then. Is that amenable to you? And maybe Senator Mitchell may want to comment. She got her mic up.
I just wanted to make sure I was clear about what you're asking of the member. Are you saying that you're going to hold it in committee and this work will be done? Well, I want to understand the process.
We can't technically hold it, but we'll pass the bill through, work on it up until appropriations, hopefully have a resolution, and then if not, then the bill doesn't move any further.
And when you say resolution, given how relative far apart the proponents and opponents continue to be, and I'm looking at a bill that's had pretty substantial amendments since April. You know, what do you mean by resolution where there's? Okay,
It's to address what the proponents are proposing to get to.
And the policy questions in the analysis?
Right, and what I would like to see is how do we place those patients somewhere? We need to figure out where we're going to get them and appropriately get them so that it doesn't happen like what Senator Ross said, that they end up jumping off a building and.
Whoever gets to send them and has the authority to send them someplace, that there is a destination point.
There's a destination from, and how do we get that? And this is a difficult, conversation, but, I think I'd rather get it right than just pass it for the sake of passing it, and I don't think this is the answer right now.
Thank you, Senator, for your suggestions, and we've worked pretty intensely with proponents and opponents to get to a few of those issues. We had a meeting this past Friday, And we think we may be moving in the right direction and are committed to working very closely with this committee to see a way forward. I think that this committee appreciates that the consequence of doing nothing will be quite severe. In our county alone, Senator, you know that the way that we cope with the lack of psychiatric beds, the 2,500 that are down since the early 1990s statewide, but in our county acutely, is that we have a jail that's a mental health facility. That's how we cope with it. That's how we deal with the frequent flyers who are homeless, who have overwhelmed their families and the system. So we think there are much more insightful and intelligent ways to move forward. Some proponents, or rather opponents, may not be able to get to yes, but we hope that they can get to some form of resolution, and we would love working with you to help bring that conversation forward.
So I'm assuming you're accepting my proposal.
The framework of your proposal is one that we've already been working on, and we actually hope to get there ourselves, particularly with training, because earlier this year, late last year, training was a big part of any new provider that would be allowed to place a hold.
Okay, so it's yes.
You had me at hello.
Okay, thank you. Yes, Senator Mitchell.
The reason I asked for clarification in terms of, in your eyes, Mr. Chair, what is success is just because I, hate to be the naysayer, but to expect that between now and approach, that we're going to be able to get to a place where we include in this bill clarity around where patients will be treated feels incredibly optimistic to me, but I'm going to put my faith and belief in the hands of the Assemblyman and the Senator, and then come get you both if we don't get there. Assemblymember, what gives me some cause for pause is when I look at the opposition and recognize that it is filled and there is no representation in your support side from groups representing the impacted community. I fully understand the challenges the ERs are experiencing. I get that. But I am hoping that in the ongoing dialogue that representatives, organizations that represent the impacted communities can be brought to a place of at least some agreement. That's just my general hope.
Thank you. And Senator Roth, did you have an additional question?
Well, just a comment, Mr. Chair. In addition to training for the emergency department physicians themselves, I also heard some comments about staffing and some other process and procedure issues in these undesignated facilities. And I think that, I don't specifically know the detail. I'm not in this field, but I think that probably will need to be addressed by you, Assemblymember, as well.
Thank you, Senator.
Okay.
Yes. I'd move the bill, and I don't need more work, but I'd like to work with you on this, Mr. Chairman. I really care about the area. It's very important.
I agree, and I think this is an important issue.
The understanding of what...
Yes, and we all agree that there's a problem. I don't know if this is the solution to the problem, but I think we need to have resolution. Yeah. So with that, Assemblymember, would you like to close?
I would respectfully request an aye vote.
Thank you. We have a motion by Senator Nielsen to do pass to Rules Committee. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Mitchell, aye. Monning. Nielsen. Nielsen, aye. Pan. Pan, aye. Roth. Roth, aye. Wolk.
That's 5 at this point, enough to get out. We're going to place that bill and call.